Okay, so we're going to start off today by going over the assessment of fetal growth, while the baby is in there. How do we monitor the baby to make sure that the baby is doing okay? So, long time ago, there were not many ways of figuring out how the baby was doing in the womb. But with modern technology, we can monitor the well-being of the baby while the baby is growing. So those assessments are what we're going to look at. Let me see. So the first assessment that we're going to talk about is ultrasound. While the baby is in there, the mother can have ultrasound done, and then we'll figure out the status of the baby. Ultrasound uses high-frequency sound waves. The waves are transmitted from a handheld transducer. Usually they have a handheld transducer. They put like KY gel in it and just kind of like rub it on the mother's stomach, and then that can, give them a lot of information about the baby. Some sound waves are absorbed by the organs and the tissues, and others are reflected back to the transducer. The reflected waves are converted to a screen image, so you can see what is in there on the screen. Also, there's what is called the transvaginal ultrasound. That one is used to determine the well-being of the baby in the first trimester. Okay, when the baby is still very small and is down there in the mother's pubis area. Uses of ultrasound. It can be used to identify pregnancy, to determine whether somebody is pregnant. Can be used to determine if a mother has twins. Determination of fetal age, growth, and maturity. Observance of polyhydramnios or oligohydramnios. So whether the mother has enough or too much amniotic fluid, or maybe they don't have enough. It can be used to detect fetal anomalies. Determination of fetal depth. Determination of fetal position. It can be used during amniocentesis. Now, amniocentesis is a process by which they go in there with a needle and draw some amniotic fluid, and then they're going to test it for several things. Okay? Determination of placenta previa. We're going to talk about that later on. So here is amniocentesis. It is obtaining a sample of amniotic fluid. Okay? They use a 20 to 22 gauge needle guided by ultrasound, and then into the amniotic sac, and then they get some of that fluid. Some complications associated with that are trauma to the baby, okay, infection, and hemorrhage. So they have to be very, very careful. The collected fluid is used for testing fetal well-being. And then these are the things that they test using the amniotic fluid. The first thing is determination of lung maturity. Okay? Like we said, when was it? Last Friday. No, not last Friday, Wednesday. Okay, that's when we started. The normal LH ratio is 2:1. If there is twice as much lecithin to sphingomyelin, those are two types of phospholipids in the amniotic fluid, then that would mean that the baby's lungs are mature. They can test for presence of PG, phosphatidylglycerol. That's the mature type of surfactant that begins to appear at the 35th week of gestation. So if it is present in the amniotic fluid, then the baby's lungs are also mature. And then they can do lung profile. Okay, lung profile is when you're making sure that your LOS ratio is 2:1, plus you have PG in the amniotic fluid. So it is a better predictor of baby's lung maturity than doing the LS ratio or the PG by itself. Another thing that they can test with the amniotic fluid is what they call the alpha fetoprotein. That is the main serum that the baby grows in. Okay? It's inside the baby. So they test the presence of it in the amniotic fluid. You're not supposed to have a whole lot of it in the amniotic fluid, but if you have a whole lot of it, it would mean that somehow there is laceration in the baby's skin, and that's why it's pouring out into the amniotic fluid. So when that happens, it can be that the baby has some kind of neural tube defect, like spina bifida, where the spine did not close well. So the spine did not close well, or maybe it can be an indication of Down's syndrome. They can also test the level of bilirubin in the amniotic fluid. Now, bilirubin is a lab value that we use to determine the function of the liver, how well the liver is functioning. Now, it is formed mainly from the breakdown of erythrocytes, which are red blood cells. So once the red blood cells break down, bilirubin is formed, and then the bilirubin usually will be transported to the liver. And the liver is responsible for conjugating. Okay, what that means, the bilirubin is a fat-soluble substance. It is fat-soluble substance. But when it goes to the liver makes it a water-soluble substance before it is peeled out from the body. So conjugated bilirubin will be bilirubin that has already been to the liver and made water-soluble. Okay? Unconjugated means that it is still fat-soluble bilirubin. That is more dangerous, okay, than the conjugated bilirubin. Okay? So, if we have increased bilirubin in the amniotic fluid, that can be suggestive that something is happening with the baby's red blood cells. Something is breaking down the baby's red blood cells. Now, there is a condition called the hemolytic disease of the newborn. Hemolytic disease of the newborn. This is where antibody from the mother attacks the baby's red blood cells. Okay? So now, this hemolytic disease of newborn is also called erythrocytosis. That's another name for the hemolytic disease of the newborn. And it's basically where antibiotic made by the mother is attacking the baby's red blood cells and breaking them down. Okay? It can also mean that the liver is not functioning well enough because the liver is responsible for conjugating the bilirubin. So if you have so much of it, that means that the liver is not working well. Well, let's look at hemolytic disease of the newborn. Okay? On the surface of everybody's red blood cells, some people have a strand of protein on the surface of everybody's red blood cell. Not everybody, some people will have it, some people will not have it. But if you have that protein on the surface of your red blood cells, you will be Rh positive. That's blood typing there, blood typing. You'll be Rh positive. If you don't have that strand of protein, then you will be Rh negative. Okay? So what happens is that when a mother gets pregnant with a baby that is Rh positive, okay, meaning that they have that protein, okay, that is an antigen to the mother. So in response to that, the mother makes antibiotic, okay, against that antigen. The mother makes an antibiotic against that antigen, okay? If the mother gets pregnant again with a baby that is Rh positive, the second pregnancy, usually the first pregnancy is not a problem, but the second pregnancy, if the mother gets pregnant again with Rh positive baby, then those antibodies that the mother made in the first pregnancy will cross over the placenta and attack the baby's red blood cells. Okay? By so doing, there will be increased level of bilirubin. So anytime a pregnant woman has increased level of bilirubin, we have to really suspect that maybe something is going on. Either that the liver is not good enough to process the bilirubin, or maybe something is attacking the baby's red blood cells. Any questions about that? So now, if we know that the mother developed antibiotics in the first pregnancy, and now they're pregnant with another baby that is Rh positive, there is, are you supposed to be here?
Oh, no, sir.
Okay. There is a shot that they can give to the mother, okay? RhoGAM shot is what they call it, the RhoGAM shot. Is what is going to prevent those antibiotics that the mother made from attacking the baby's red blood cells. Any questions about that? And then we have creatinine level. We can test the presence of creatinine in the amniotic fluid. Now, creatinine is used to assess the function of the kidney. Okay? It's just one of the lab tests that we can use. We have creatinine, and then we can also have the BUN, blood urea nitrogen. It's also a lab value that we can use to assess the function of the kidneys. But creatinine is a better value. Okay? Creatinine, normal creatinine is usually like 0.7 to 1.1, somewhere there. 0.7 to 1.1. And then the BUN is usually like 7 to 23. Okay? But now, as the level increases, as gestational age progresses, normal maternal level indicates fetal kidney maturity. Okay, so if the mother has normal level of creatinine, that will also mean that the baby's kidneys are matured. And then we can also test and see if there is meconium in the amniotic fluid. Meconium is baby's poop. Usually babies don't poop in utero. Okay? If they poop, then that would mean that they're in some kind of distress. Okay? If we know that, then we can better prepare for the baby being born. Okay? Because we have to make sure that the meconium is not occluding their trachea. So it is a sign of distress when we see that. And then cytology examination of the cells, that can also be done. We use some of the amniotic fluid, okay, to see if the baby has some kind of genetic disorders, such as Down's syndrome. Okay, so the next thing that we can assess what the baby is in there to make sure the baby is doing well is the baby's heart rate. Okay? The fetal heart rate corresponds to fetal well-being. If the fetus has normal heart rate, then that would mean that the baby is fine. The fetal heart rate is 140 to 160. Now, some books may say 120 to 160. That would be fine. 140 to 160 beats per minute. Three methods can be used to measure or determine the fetal heart rate. The first one is we can use a standard abdominal transducer. It's handheld. They rub it in the KY jelly and then put it against the mother's stomach, and then we'll find the baby's heart rate. It tells us how much it is. We can also place electrodes on the mother's abdomen, and then be able to determine the baby's heart rate. And the third way is what they call the fetal scalp electrode. This is during labor, when the baby is coming out. For some reason, if the baby is not coming out fast enough, then it will be imperative to monitor and see how the labor is affecting the baby. Okay, so they put, once the baby's head come out a little bit, they will put that electrode, on their head, so that they can monitor their heart rate while labor is going on or birth is going on. Determining fetal heart rate. Okay, so how do you know? Because every fetus is slightly different. Okay, how do you know what would be a normal heart rate for this fetus? Okay, because it's not exactly the same for every baby in there. Okay, so what we have to do is to watch the baby for 10 minutes and get what their baseline heart rate is. Okay, we'll watch them for 10 minutes, count their heart rate, average the heart rate in 10 minutes will be that fetus heart rate. So, but the heart rate usually for all of them will fall between 140 to 160, okay? But you may get a baby that is 145 or 150 or runs 160. So if I know that the baby normally runs like 145, and then all of a sudden their heart rate is over 160, well, that will be a problem, okay? Heart rate variability, okay? Now, a healthy fetus has to have heart rate variability. Their heart rate has to vary, okay? It can't always be 145 always, okay? Sometimes it may go up a little bit, sometimes it may go down a little bit. Okay? That's the way it's supposed to be. Now, if a baby has heart rate variability, then that would mean that that baby is healthy, okay? Because the heart rate is supposed to vary, especially with movement, okay? If the heart rate doesn't vary, there's no beat-to-beat variability, that would mean that the baby is compromised. Bradycardia and tachycardia. For a baby bradycardia means a heart rate that is less than 100 beats per minute or a maintained drop of 20 points from baseline. Okay? So if I know that my baby's heart rate is 145, and then the heart rate now goes down to 125 and stays there for a while, so that will mean that the baby has bradycardia. Okay? What are the possible causes of bradycardia? Asphyxia. Asphyxia is deprivation of oxygen to the baby. Somehow the baby has been cut off from getting oxygen from the placenta. Okay, either maybe the umbilical cord pinched off, okay, and the oxygen is not getting to the baby. That will cause the baby to develop bradycardia. Kind of like the same thing with an adult, because now if you remember an adult, if you don't have enough oxygen, the very first thing that happens is you have tachycardia. If you're still not providing oxygen, then you go into bradycardia. Okay? So hypoxemia can cause both tachycardia and bradycardia. Okay? The initial response is usually tachycardia, and then after that you get bradycardia. Okay? Congenital heart block can also cause that, cause the baby to have deceleration. If the baby is cold, hypothermia, okay? Low body temp will cause your heart rate to go down, okay? Including in adults. Okay? If you're very cold, your heart rate goes down. Tachycardia for the baby is defined as a heart rate that is greater than 180 beats per minute. For us, it's greater than 100. Well, the baby is greater than 180. Possible causes of tachycardia. Sympathomimetic drugs administered to the mother, like albuterol, Zopiness. Albuterol resists the heart. It resists the heart of the mother, and it can arrest the heart of the baby as well. If the mother has infection or the baby has infection, infection always demands oxygen, okay? And when that happens, the baby's heart rate is going to go up, okay? If the mother is dehydrated, okay, that can cause the baby to have tachycardia. And then asphyxia as well can cause tachycardia. Now remember, asphyxia is just not the baby not getting oxygen, but it is hypoxemia in the baby. So like I said before, initially you will have tachycardia, and then after a while, if oxygen is still not being provided, then you have bradycardia. Any questions? Now, there is something called acceleration of the baby's heart rate. Acceleration of the baby's heart rate. And that is when the baby's heart rate increases over 160 per minute for 2 minutes. Now, this is usually during delivery. Okay? Now, during delivery or during labor, if the baby's heart rate accelerates, that's actually a good sign. It's a good sign that the baby is responding well. Okay? But if the baby's heart rate does not accelerate, then that means that that baby is having some problem. Okay? So acceleration is a good thing during labor or delivery. Okay? It is a sign that delivery is going in the right direction. And then deceleration is when the baby's heart rate drops below 120 for 2 minutes. Okay? 2 minutes. Somehow the baby is not getting oxygen. Okay? And that's what's going to cause their heart rate to drop below 120. There are 3 types of decelerations. The first one is what they call the early or type 1 deceleration. And that is caused by fetal head compression against the cervix. Okay, if the baby is coming out, okay, and the head is compressed by the cervix, that can cause the baby's heart rate to decelerate. The heart rate drops below 120. And then they have lead or type 2 deceleration. This one here is caused by uteroplacental insufficiency during contraction. So during contraction, the stress goes up. The placenta may not be able to keep up because the placenta is squeezed as well. May not be able to keep up providing enough oxygen to the baby. Okay? So if that is happening, then that means that the placenta is not really doing a good job. Okay? The viability of the placenta is not as good. Okay? So that will cause that deceleration. Okay? It will cause asphyxia to the baby because it will not be providing adequate oxygen to the baby. And then they have variable or type 3 deceleration. This one here is independent of uterine contraction. Okay, it is mainly caused by compression of the umbilical cord. Compression of the umbilical cord. If you compress the umbilical cord, you are compressing the umbilical vein, because inside the umbilical cord you have the umbilical vein and the 2 umbilical arteries. Okay. Now this is what normal pH of the fetus looks like. 7.25. Okay, they're acidic when they're in there. Okay. But now we can do a blood gas. We can use like a fetal scalp pH assessment and check on their pH. Now, if you run it, and the pH is between 7.2 to 7.24, that would mean that the baby has slight asphyxia. If it's less than 7.20, then the baby has severe asphyxia. So what is considered normal is 7.25. Now remember, I told you that once a baby is born, you don't always expect them to have normal pH like us, because it takes a while for them to develop more alveoli. Okay? The development of alveoli continues through the pediatric years. So as a result of that, if a baby has a pH that is 7.30 or a little higher, that would be good. You don't need to react to that. Estimating the delivery date, or sometimes they call it estimated date of confinement. When is the baby due? When is the baby due? Several ways that they can tell how many weeks the baby has been in there and how many weeks that they have left to come out. Okay? The first one is what they call the Naegeli's rule. Naegeli's rule. When I use the Naegeli's rule to determine estimated date of confinement when the baby is due, what we're going to do is we are going to subtract 3 months from the first day of the mother's last menstrual period. And let me say that again. You subtract 3 months from the first day of the mother's last menstrual period, and then you add 7 days to it. So let me give you an example. So if I'm using like, let's say like the last day The first day of the last menstrual period of the mother was March 25th. Okay? We're going to subtract 3 months to it. We'll go back 3 months, and that should put us to like December 25th. And then we add 7 days to it. So that brings us to January 1st. So you subtract 3 months from the first day of the last menstrual period, and then you add 7 days. That's Mendeleev's rule. That's the way you determine estimated date of confinement when the baby is due. Any questions about that? The second way that we can have an idea of how long the baby is been in there and how many more weeks left is by measuring the what they call the fundal height. The fundal height. So now this is the fundus is the end of the uterus. The end of the uterus opposite to the cervix. The end of the uterus opposite to the cervix. So what happens is that as the baby grows, so you start from here, as the baby grows, the fundus grows up like that. Okay? It's from here going up. So as the baby grows, the fundus grows. Okay? So what doctors do then is they measure the length of the fundus. They use like a tape, okay? And then they put it right here, and then they measure the mother's abdomen, okay? And then it comes out in cm, centimeter, okay? If they measure like 20 cm, and the fundus is 20 cm tall, then that would mean that the baby has been in there for 20 weeks, okay? If the fundus is 5 cm tall, then the baby is been there for 5 weeks. Okay? So if we measure 20 weeks, which would be 20 cm, then the baby has 20 more weeks to be in there. And then we can go from there and count 20 weeks. And then that will give us the date of delivery. Are we on the same page? Okay, fundal height. All right, so another way that they can do that, have an idea of how much time that is left or how long the baby's been there, is what they call quickening. Quickening. Now, quickening is the very first baby's heart sound. Okay, the very first baby's heart sound that you hear. Okay, and doctor listens to it. And usually the first heart sound is heard between 16 to 22 weeks. That's when you're going to hear their heartbeat. So if you hear that heart sound, then you're going to say, well, the baby's around 16 to 22 weeks. And then that will give you an idea of how much time left or when the delivery date will be. Quickly. Okay. Any questions about that? Usually, if you use a Doppler, you can hear it earlier than that. Okay. Or if you use a Doppler, you can hear the baby's heart rate earlier than that, a little bit earlier than that. Okay, so here's another way to determine how well the baby is doing in the womb. This is called the biophysical test of fetal well-being. Okay? This one here is called the contraction test, contraction stress test. Usually we subject the baby to stress Okay, they subject the baby to stress, probably by limiting the amount of oxygen supply to it. Okay? A normal baby would have a decrease in heart rate when you limit the amount of oxygen going to it from the placenta. You put the baby under stress. They should have deceleration. Well, if the baby is not doing well, there will not be any deceleration. Okay? Remember, the deceleration is when the heart rate drops below 120 for 2 minutes. Okay? Babies have to be moving around. If they don't move around, it is a sign that something is wrong. They may not be doing well. There's another test called the non-stress test. Okay? And this one here is based on the fact that the fetal heart rate corresponds to fetal movement. The fetal heart rate corresponds to fetal movement. Okay? If the baby is moving around, the heart rate ought to be going up. If the baby is not moving around, well, the heart rate will not be going up. Okay? So if the baby has acceleration, okay, during movement, the mother is moving around, making the baby to move around, the baby's heart rate should be moving up. Okay, so that would be positive acceleration. Okay? And then if the heart rate is not moving up when the mother is moving around, well, that can indicate some problems. Another way is by using or doing what they call the vibroacoustic stimulation. They use a buzzer, okay, make some, noisy stuff, on the mother's stomach, okay. The baby listens to it. The baby gets scared. Okay, the baby gets scared by hearing that noise. Their heart rate ought to be going up. Okay, the heart rate ought to be going up. If the baby's heart rate does not increase when a buzzer is placed on the mother's stomach, then that baby could be compromised. Something may be wrong with it. And then the last thing there is that babies ought to be able to move at least 10 times in 1 hour. Okay, at least 10 times an hour in 1 hour, they should be moving. And sometimes the mother may be told to write down how many times their baby is moving in 1 hour. Okay, if your baby is not moving at least 10 times in an hour, then that baby could be compromised. Any questions? Am I going too fast? Okay. Yeah, today is Friday. I want to see if I can. All right, so amniotic fluid volume. Amniotic fluid volume, okay? Now, that can reveal some abnormalities such as esophageal atresia. Like we said last Wednesday, a baby is supposed to be swallowing the amniotic fluid and peeing it out. Okay, they swallow it, they pee it out. Okay. So now, if there's plenty of amniotic fluid at birth, polyhydramnios, that would mean that the baby was not swallowing the amniotic fluid. So as a result of that, there is obstruction in their esophagus. And that is what we call the esophageal atresia. Atresia means obstruction. Okay, so the amniotic fluid volume can tell us that. Okay? Diaphragmatic hernia can cause that as well. Now, later on down the line, we're going to go over that, but diaphragmatic hernia is like when a baby is born with all the intestines up in their chest. Instead of the intestines in the stomach, they are moved up to their chest. Okay? They have like a flat stomach. I can also indicate urinary tract abnormality when the volume there is too much. Meconium present in the amniotic fluid. Anytime meconium is present, the baby is in distress or may have been in distress because they're not supposed to poop in utero. Okay? One of the things that happens to a baby that is postpartum, a baby that is born after 42 weeks, is meconium. Okay, presence of meconium in the amniotic fluid. Okay, they have they may develop what we call meconium aspiration syndrome. So when we know that a baby is going to be born with amniotic fluid stained with meconium, we'll be ready for resuscitation so that as soon as the baby comes out and the baby is not vigorous, the baby is not crying, or maybe they have poor muscle tone, poor color, they have cyanosis, we are going to quickly suction the baby's trachea out. Okay? And usually before they take their first breath. Chorionic villus sampling is also a way of monitoring the well-being of the baby. Okay. Chorionic villus is removed from the placenta and the sample is tested for chromosomal abnormalities. Genetic disorders, that's what that means. Genetic disorders. The chorionic villus is part of the placenta. Okay? It's like the smallest unit of the placenta. And then there is choriocentesis. Choriocentesis. We're going to draw blood from the umbilical cord. Usually respiratory therapists do this. They get the blood and we can test that blood for everything that you're looking at there. We can test for hemoglobinopathy. That would be like sickle cell, sickle cell anemia, hemoglobinopathy, sickle cell anemia. See if the baby has sickle cell anemia. We can test for coagulopathy. Make sure that the baby's blood is going to clot well. Okay? There are some clotting factors like calcium, okay, prothrombin, things like that. Make sure that the baby has all of that. We can test for metabolic disorder. We can test for oxygenation, okay? We can test for acid-base balance. You check their CO2 as well as their bicarbonate. Okay, choriosynthesis. And these two here are called the biochemical methods of assessment. Biochemical method of assessment. Both of them are metabolites of estrogen. Estrogen is like a female hormone. Metabolism of estrogen produces these two chemicals. The first one is maternal estrol determination. Okay. Now, the estrol is secreted by the placenta. It is in the mother's urine. A pregnant woman pees, and then they check the level of estrol in it. Normal level means that the baby's liver and the adrenal glands are functioning well. I have a little typo there. Yeah, normal level of estrol in the mother means that the baby's liver and adrenal glands are functioning well. If there is 50 to 60% decrease from the previous sample, that would indicate fetal distress. So the level of estrol, okay, secreted by the placenta is supposed to increase as gestation progresses. Okay? They check it almost throughout the pregnancy, especially in the third trimester. Pregnant woman goes to the doctor almost at every visit. They have to pee, okay? And then they determine the level of estrol in the urine. And then the last one is another metabolite of estrogen. Okay, now that one is called the human placental lactogen. Human placental lactogen. Okay, this is secreted in the maternal blood. So they would have to draw blood to check on that one. Okay? Again, the level of human placental lactogen is supposed to increase, okay, as gestation progresses. So if there is a significant drop in that, okay, from the previous visit, that would mean that the baby is in some kind of distress. Any questions about fetal assessment? What time is it?
About 2.
2. You want me to keep on going so we can finish, or you want a break? Well, let's take 10 minutes.
Yeah.
Let's take 10 to 15 minutes and then we'll finish the other lecture.